So welcome everyone to today's webinar, and it's a joint initiative from ERNICA, from EUPSA, and also from ESPGHAN. And the initiative to this has started from ERNICA, where we're developing a nutrition working group. And so we thought this was a great opportunity to reach out between the three organizations and have some cross-fertilization of ideas. And so we've got three speakers today. Annika Mutanen, who's a paediatric surgeon from Helsinki. Professor Kostas Geramidis from Glasgow, who's a gastroenterologist, and Louisa Telborn, who's a paediatric dietitian. So first of all, Annika is going to start us off, and she's going to present a case study by way of getting us starting to think about nutrition and malnutrition, specifically in pediatric surgical patients. But before I hand over to Annika, I'd like to just say, please hold off your questions until all three speakers have given their talks. We'll take questions right at the end. But at that time, there should be plenty of time for questions, but we want to make sure that everyone has time to speak and give their full talks. So without any further ado, I will hand over to Annika.
So good afternoon to everyone, and I'm very, very pleased to have this chance to talk about nutrition. I will share my presentation in a second. Yes. So I'm trying to approach the topic of nutritional status and surgical patients. I will go through overall things related from the literature, and then also wrap this around a real patient case. So as an overview, nutritional status is a key determinant of postoperative outcomes in children. This is very, very important to remember when working with pediatric surgical patients. We know that both undernutrition and obesity affect wound healing, infection rates, and recovery. And further, children are more vulnerable due to higher metabolic demands and limited reserves. For surgeons and also all other professionals who work with and try to help pediatric surgical patients, it's very important to know that it's important to also look at nutritional aspects when as a part of the management. Malnutrition strongly predicts poorer surgical outcomes in children. This most importantly includes increased infection rates in patients who are malnourished, longer hospital stay, and increased number of reoperations needed. But good thing in here is that if we do early optimization of nutrition status, we will improve recovery and reduce complication rates. If we go for more details, like what types of problems will happen if we're not paying attention on nutritional status in surgical patients, for example, reduced muscle strength leads to respiratory complications. For example, longer ICU stay and need for ventilation, or for example, infectious complications in lungs. Especially protein energy malnutrition is known that it will impair wound healing, and also cause immune dysfunction. It's very well shown that hypoalbuminemia is related to higher rate of need for ICU admission after surgery, and also higher rate of surgical complications. Then if you look at detail for micronutrient deficiency, this also is important when you consider epithelial repair and how things are healing after surgery. Also, electrolyte imbalances can cause high rates of complications, and especially in infants who are at increased risk. So there are many reasons why we should be very careful on nutritional status before surgery. What could we do then? How we should approach the topic before surgery? The aim for optimizing nutrition intake and use of all intestinal absorption surface prior to surgery should be first priority. And if it's not possible to improve the nutritional status with enteral nutrition, either orally or enteral supplementation, we should then add parenteral nutrition on top. We also should avoid starvation to minimize negative protein balance before surgery. We know that this negative protein balance is not good for maintaining muscle, immune, and cognitive functions. And also, it's unnecessary to keep the patient MPO for long times before surgery. With these actions, we can enhance recovery and more faster return to baseline functions. The options for improving nutritional status would be nutrition education and diet modifications, oral supplementation, enteral or parenteral nutrition support, or then possibly nutrition-focused medical therapy. Maybe most recent and most obvious medical therapy that would really improve nutritional status, for example, in intestinal failure patients who are very easily malnourished, this medication would be teduglutide, the GLP analog. Then also, we need to think how long we should try to improve the nutritional status before surgery. We should first think that, is this surgery really needed now, or could we wait for a while? If this is medically possible, then it's usually worthwhile if you want to avoid the complications. If there is severe malnutrition, rule of thumb could be that you should aim at least for a 10% increase in body weight, or to reach the level of weight Z-score -2. In mild to moderate malnutrition, it should be at least that there is around 2 weeks of improvement time. So this will already help to avoid the complications. All right, then we go for the case. This case is originally it's a baby boy who was born at 30 weeks of gestation, so was premature. And due to the prematurity, baby boy had necrotizing enterocolitis diagnosed at 7 days of age. This disease progressed very fast, and in 24 hours after the diagnosis was made, already bowel perforation was seen in the x-rays. This baby needed 3 surgeries during first 4 weeks of life. First surgery was for the perforation. second surgery was to take out more necrotic bowel, and then the last surgery was to fix prolapsed bowel, prolapsed stoma, to prevent losing of that piece of bowel, which was very essential after multiple resections the baby needed previously. After these surgeries, the baby had left only 43 centimeters of jejunum, then a separate piece of ileum, 80% of colon, and no ileocecal valve. This is a real life picture of this baby who had these 4 stoma ends at the skin. So one stoma end on left is coming from the jejunum, then the second from the left, it is the ileum, and then the second piece, like the end of the ileum, is on the right, on the medial, and then on the right, most lateral, is the colon. The wound care was very, very challenging, and the stoma secretions tend to go to the skin and burn the skin open again and again and again, and baby had also infections to this. Baby was dependent on total parenteral nutrition and had cholestasis when arriving to our care. Then we started to think that how we could help this baby. He was around 1 month of age at the stage that we approached this baby with our multidisciplinary team. It's very important to think the problems together and not individually. We need to think about how we could improve oral feeding, how we could improve the parenteral support, and if there is anything else we could do to correct, for example, the micronutrient deficiencies. In our team, we had pediatric surgeon, neonatologist, gastroenterologist, nutritionist, wound care nurse, stomach care nurse, to all together to see how we could get this baby growing and improve things. We started oral feeding for the baby who he previously did not have any oral feeding during his life, but we started this, and we always tend to prefer human milk if this is available. We also looked at the parenteral support to be sure that we would follow the usual guidelines for lipids and all other nutritions that there are. We diminished the lipid amount quite a lot. Also made sure that there is MOF and fish oil used. We also tend to regularly follow up lab work of different aspects, also considering nutrition like electrolytes, iron, liver function, and vitamins, albumin, and TT. We also want to use all the absorption surface to improve the absorption from the bowel and to be able to decrease the amount of parenteral nutrition. We routinely, always when possible, take the stoma output and put it back distally. And also in this baby's case, we used all the 4 stoma ends. So we collected from the first bag the stool, refeed it back to the ileum, take it back from the second stoma bag, and refeed it to the colon. We aim refeeding all proximal stoma output down the distal limb. And this, of course, we try to mimic a state of intestinal continuity like it would be when the stomas are okay to be closed. At this point, when we saw baby, one would think that why would not just close the stomas, but this baby exactly had all the risk factors to have lots of complications for the enteroanastomosis healing, for skin wound healing and infections. So we didn't want to take this risk. Also, baby was still very unstable because of the prematurity issues. With this refeeding, we aim for improving nutritional outcome. We aim to promote intestinal adaptation, so keeping all the bowel that there is in good shape. And we want to ensure that enterohepatic circulation is there happening, and we will, with this, protect also liver. With these actions, you will see the growth of this baby. Z-score for height is on orange, and then for weight, it's on blue. So when we started, the diagnosis of malnutrition is the 0, and then the weeks that we improve things are those 2, 4, 6, and 8. And we aimed for at least weight Z-score -2, and then we thought that this with this measurement could be the spot for surgery. And for this baby, the surgery was done after 6 weeks of improvement. But this wasn't the only thing we looked at. One of the things we also, from lab work, we can see that really things improved during the 6 weeks of preoperative optimizing. Albumin levels went up. Bilirubin levels, both total and conjugated bilirubin, started to decrease. And hemoglobin and iron deficiency, these also improved. So 6 weeks of lots of work, we managed to improve the baby's weight and height. We managed to improve the lab work. We managed to improve also the wound care, and we managed to get all of the wounds healing, and the skin looked normal at that point at 6 weeks. Post-operative recovery for this baby was very uneventful. In the surgery, we connected everything, so closed the stomas and made the enteroanastomosis, and baby was able to poop again normally. We always, after surgery, also need to take care that we will not have steps back. We will need to have steps forward. We always aim for early enteral feeding and avoid prolonged fasting. We always start enteral feeds orally, we prefer. As soon as the nasogastric output is low, it doesn't need to be 0, but it's getting lower. And when the child is exhibiting signs of hunger, and we will give them, we will let them eat as baby is tolerating. And as soon as nasogastric tube is not needed anymore for decompressing the stomach, we will get rid of that. We will take it out. We also continued parenteral nutrition. Of course, this baby had quite short bowel left, so we needed to continue this as a supportive nutrition to avoid that the baby is not overfeeding, over orally feeding, and then to avoid typical intestinal failure type of patients' complications, such as long-term dilatation of the bowel after overfeeding. But this baby was able to wean off PN after the next few months. For this baby and other babies, we tend to always look at what is left from bowel when we need to follow these patients considering nutritional status. We always need to think what's left and what is not there. If ileum is resected, we need to remember that bile acids and fat absorption is not normal. fat-soluble vitamins and B12. The absorption is not normal, and there might be deficiencies in these. Also, fluids and electrolytes are lost much more than usually, and GLP-2 is also normally secreted from the distal ileum. So if this is resected, especially in patients who have real intestinal failure, we need to remember this. If the ileocecal valve is resected, we need to remember that the risk for a bacterial overgrowth is there also long-term, also in patients who are not intestinal, who do not have intestinal failure. After colonic resection, electrolyte and fluid balance might be abnormal. Patients tend to lose lots of fluids and electrolytes, and also absorption of short-chain fatty acids is abnormal. And of course, if there is major small bowel resection, all of these components need to be followed up carefully. For this patient and also other patients that are such that I just described, we also continue multidisciplinary approach for the long-term follow-up when they come for the outpatient clinics. Our standard protocol for this type of patients would be that we would look at the anatomy and look at the patient growth, and also a little bit tailor the post-op follow-up. But the minimum you would see here, we would have the hospital stay. Then after 1 month, 3 months, 6 months, 9 months, and 1 year after discharge from the hospital, we would minimum see them. And then after 6 to 12 months every year, we would look at nutritional status, growth, and gastrointestinal symptoms. So key points from this first part of the webinar would be, when considering nutritional status and surgical outcomes, malnutrition strongly predicts poorer surgical outcomes in children. Early detection and optimizing before surgery is important to improve recovery and reduce complications. It's good to adopt multidisciplinary approach to all of these patients, and routine nutritional screening, which we will hear in the next 2 presentations, should be part of routine pre-op pediatric surgical practice and management. This was my part. Thank you very much for listening.
Thank you very much, Annika. And we're very pleased of your presentation. I take the time just to introduce myself. I'm Dr. Lorenzo Norsa, and I'm part of the ESPGHAN and of ERNICA. And I'm very happy to have you all here in the afternoon in this webinar. And it is my pleasure to introduce Professor Konstantinos Gerasimidis, which is a great friend and a professor in nutrition in the University of Glasgow. And he will try to give us a talk on how we can look at nutritional screening tool and how to build some new nutritional screening tool, because she have done a lot of research in this field. So thank you very much, Kostas, for accepting this invitation, and the floor is yours.
Thank you very much, Lorenzo, for the kind introduction, and of course for inviting me here today. Can you all see my slides? It's all good, I guess. Okay. Yeah, great. So my name is Kostas. Sadly or not, I'm not a pediatric gastroenterologist, as Simon mentioned. I am a dietitian by training, but I'm currently a professor of clinical nutrition at the University of Glasgow, which is the 4th oldest university of the English-speaking world, and I have spent a lot of time in trying to develop, but most importantly, implement malnutrition screening tools in routine clinical practice. I think ERNICA did a great presentation to highlight the importance of nutritional status and how this can influence disease outcomes in patients, in this case with surgical kind of like conditions. But outside her presentation, there are worldwide several standards and several guidelines of nutritional care, which pretty much highlight two important things. First of all, how important is undernutrition for patients' disease outcomes and disease prognosis. And kind of like in this slide, I try to summarize what we currently know. We know that undernutrition can happen. It's not as common in kids as it is in adults, particularly in elderly, but we know that approximately 1 in every 10 children who are admitted in the hospital can be at risk of undernutrition. Undernutrition relates with poor outcomes. Most important, we can prevent undernutrition in a substantial proportion of patients, and there is some scarce evidence, but very important one, to suggest that if we intervene in these children who are at high risk of undernutrition, they can improve their clinical outcomes. But the second thing that these guidelines and position papers and standards of nutritional care talk about is this concept of how nutritional care should look like. So on this slide, I pretty much summarize what we currently know, and this is pretty much how we practice in clinical practice. So we know that before we are able to think about food fortification, about supplementation, about enteral parental nutrition, the basis of this nutritional care plan should look at nutritional screening. And for those of you who are not familiar with the concept of nutritional screening, this is a process that you have to apply to every single patient who comes in the hospital. So, for example, let's say you work in your pediatric setting, in your academic or smaller district general hospitals. So you screen every single person who is coming in your hospital, who is admitted in your inpatient wards, and then we would expect that the majority of these children, after they receive this screening, will be at low risk of undernutrition. So as I told you before, pretty much 1 in 10 children in a European hospital will be at risk of undernutrition, meaning that the majority of the children will not be at high risk of undernutrition. And of course, these children do not need to see a dietitian, and of course they will receive the standard hospital food. But then you have approximately 1 in 10 children who will be flagged up as at high risk of undernutrition. And it's very, very important to remember that when these children screen at high risk of undernutrition, this does not necessarily mean that these children are malnourished, okay? So the purpose of nutrition screening is to identify children who need further nutritional assessment by your hospital dietitian or by your clinical multidisciplinary treatment team. Most important, as I told you before, if these children score at high risk of undernutrition, they are not necessarily malnourished. And of course, after the children receive this full nutritional assessment, then they can either receive an individualized dietary plan, pretty much similar to what ERNICA told us in her presentation, or they can be monitored and rescreened later during their admission in the hospital. So obviously the main kind of like essence of my presentation today is to talk about screening and how is the best way to go about that in routine clinical practice. So there are some misconceptions about what nutrition screening is and what malnutrition is in general. So quite often people think that malnutrition is a child who is either short, so a child who's got a height for age below the second centile, or a child who's very, very thin. So in other words, a child who's got a BMI or a weight for height below the second centile or below -2 or -3 standard deviations. But actually, this is not what malnutrition is. And based on the consensus position paper that we published in collaboration between ESPGHAN and ESPEN, we define undernutrition as a condition. And essentially, this is a condition which is the result of negative energy balance. So in other words, your body receives less energy than it actually needs. And of course, if this condition stays prolonged, then this can cause meaningful adverse effects on your tissue function, on your body size, and of course, in the long term, this can influence negatively your health outcomes. Okay, so one of the things I would like you to remember is that undernutrition is not a low height or a low BMI or weight for height. And of course, the other complexity with trying to assess or try to screen for this condition is that we don't have a laboratory biomarker. Quite often, people use albumin as a biomarker of undernutrition, but this is wrong to do. Albumin is at best a biomarker of the disease severity of your patients. Now, the other thing you have to think when you think about screening of undernutrition is very important to distinguish between the different types of undernutrition that you may kind of like see in a community. On the left-hand side, and on this slide, you have what we call the starvation-associated malnutrition. And as you can imagine, this is the type of undernutrition which is associated with food insecurity. So we see this type of undernutrition mostly in low, medium income countries, in sub-Saharan areas, or in areas like Bangladesh. But in the majority of the patients that we treat in routine clinical practice, or the majority of the children who live in a more affluent environment, we often talk about disease-associated malnutrition. And in this case, as you can see from this graphic here, the main reason that these children become malnourished is not because they don't have food to eat, but it's because of how the disease process can influence regulators of their energy balance, how it can regulate the amount of the food they could consume, how it can regulate the number of the nutrients they can malabsorb, and of course how it can modulate their energy and nutrient requirements. And of course all of this is part of the same vicious cycles. For example, you can be kind of like suffering from starvation-associated malnutrition, and then this of course can increase your risk of becoming sick and vice versa. And this is a very quick example just to highlight how complex disease-associated malnutrition is. So this is a graphic which I published on behalf of the British Dietetic Association here in the UK. And I try to describe the presentation, but most important, the underlying etiology of malnutrition in children with inflammatory bowel disease. And as you can see, this is pretty much multifactorial. So you have always to bear in mind in that before you're able to identify these children, and of course, be able to offer the best standard of nutritional care. Now, the best way to assess a person's nutritional status, as I told you before, is not to just rely on anthropometric measurements, but it's important to use a more comprehensive approach. So we, the dietitians, are quite kind of like used with this idea of the A, B, C, D, E, or F rule. And essentially what you try to do here, you try to take a lot of information, a lot of measurements into consideration before you're able to come up with your global nutritional assessment evaluation. So you have to think about anthropometry, biochemical measurements, clinical examination, the data intake of the person, the environmental factors, and I think this is very important. For example, if you think about children who live in kind of like in an abusive environment where there is parental neglect, and of course function is very important as well. But if you think about that, to apply this comprehensive process to identify children with malnutrition is quite time consuming, and of course you need to have specialists to do that. In other words, you have to have dietitians. So as a method, obviously it's very, very effective, but it becomes very inefficient, particularly when 9 out of the 10 children who are admitted to the hospital do not need to undergo this comprehensive nutritional assessment process. So this introduces pretty much to the concept of nutritional screening, what we call NST. And for those of you who are not familiar with what the malnutrition screening tools are essentially brief questionnaires which outline main predictors of nutritional risk. So each of these predictors, we often call them steps, has a score, and then what you do, you fill in these forms. These forms shouldn't take long, should take approximately 5 minutes at maximum to complete them. And based on the total score that you come up with these nutrition screening tools, then you classify your patients either in 2 or 3 categories. The most important category are those children who are at high risk of undernutrition, and these children are referred to your hospital dietitians or to your hospital nutritional care team to receive a further nutritional assessment. And those children who are at low risk of undernutrition, they're just not seeing the dietitian. So in other words, they just receive the normal hospital nutrition and diet. Of course, when we started working in this area back in 2008, there were hardly any nutrition screening tools. Now in 2025, I think there are pretty much more than 20 of them. And each country and each hospital tends to introduce and develop their own screening tools. I'm not going to go too much in detail about that because I believe Lovisa will give you a more detailed presentation about the most important screening tools which currently used in clinical practice. But most of them do the same thing. Okay, so they try to estimate the current nutritional status of the person, and for this they use BMI and weight measurements. They try to take into consideration kind of like the past, essentially where the journey, where the patient is coming from, and for this they usually take into consideration weight loss. And of course we're also trying to think about the future, which is very, very important because a lot of these children who are admitted in our hospital may not be underweight, but because of the clinical insult they have, they may be at high risk of becoming undernourished in the near future. There are quite a lot of studies. We try to pretty much work out which is the very best of these screening tools to use. We have embarked in the largest of this study organized by ESPGHAN, and we don't feel that this process of comparing one screening tool against the other is very, very useful. So as an ESPGHAN and ESPGHAN kind of like special interest group in clinical nutrition, we believe that the most important thing is not just to try to identify the most suitable or the most valid screening tool, but it's most importantly to identify a tool that you can use obviously in routine clinical practice and you're happy with. So these are the characteristics of what I would call the ideal screening tool. So of course you want a screening tool which has good diagnostic validity. So essentially it identifies the majority of the children that you want to treat. So essentially it's quite sensitive, but it's very, very important also to have a screening tool which is quite specific, or in other words, it has a quite low false positive rate, because you don't want essentially to upset your dietitians by referring them children who do not need to be seen. But equally important is also to consider screening tools which are quick and cheap to implement, the screening tools which do not waste a lot of resources, which do not increase your workload, and of course screening tools which make a difference in routine clinical practice. And the reason that I make and I pretty much highlight that these kind of like aspects are very important in any screening tool is because when you choose a screening tool and you say, okay, I'm going to introduce this in my routine clinical practice, quite often you think that the problem is solved. So we often think that what we really need is a valid screening tool, and we just need to introduce this in routine clinical practice, and this is our job done. But actually, as soon as you do this, you realize that you activate a new cascade of problems. So when you introduce a new method in routine clinical practice, in our case a nutrition screening tool, you have to think about equipment that you have to screen patients. You have to think about the training that your nursing staff or your junior medics who often perform this screening need to receive. You need to think about the patients that you need to have to the staff you need to have to intervene, and of course you have to think about the cost of all these aspects, and of course if the cost of introducing a screening tool will be much less than the cost of not having one at all. Very important, as I told you before, is to try to do this in a collective way. So it is no point to trying to achieve something alone. So quite often dietitians in a country try to introduce a nutrition screening tool in routine clinical practice, and they often fail because they try to do this alone. Here in Scotland, we are mandated by the government. It is compulsory for every single hospital to have a nutrition screening tool in routine clinical practice. And when we developed a couple of screening tools that we routinely use here in Scotland, we try to do this by considering the various stakeholders. So we try to do that in collaboration with the dietitians, with the ward nursing staff, with the medical team, with the policy makers, and so forth. Very important thing is also about training. So it's not just important to develop screening tools. So people like me are very good in doing this, but we're very, very bad also to ask other people to use our method. So it's very, very important to make sure that before you introduce a nutrition screening tool in routine clinical practice, to make sure that you provide the right training to your nursing staff, which is what we use here in the UK to perform nutritional screening, or to your pediatric, for example, junior doctors, and this is my understanding what they use in Netherlands to perform nutritional screening. Very important to think about training. Very important also to support this process. So this is an example of how we used to do that here in Glasgow. So we introduced a screening tool. We had a nurse educator who would educate and troubleshoot any issues on the side. And of course, it's very, very important also to take into account your users' feedback. As I told you before, here in the UK, we ask nurses to perform nutrition screening tool. So it's very, very important to take their opinion into account. So this is an example of these evaluations we performed. As you can see here, when we asked nurses if they think that PIMS is easy for them to use, they told us that's not the case for all patients, okay? And we knew that because we need to measure height and weight, and nurses do not like to ask the children to stand up, particularly those children who are bedridden, to measure their height. But on the other hand, they told us that PIMS was easy to use, was easy to complete on hospital admission, and most importantly, it didn't take a lot of their time. So these are very, very important things to consider. And of course, in this slide, I summarize pretty much my 10 top tips to introduce a nutrition screening in routine clinical practice. Okay, so you have, first of all, to think about whether or not you want to introduce this in your area of practice, and whether your colleagues, not just yourself or your kind of like your specialty, is interested in nutritional screening. Then you have to think about which is the best or the most appropriate screening tool to use in your hospital. And of course, think if you need a new one. I don't think we always need a new screening tool. I think there are, as I told you, more than 20 available already. So there's no reason for some of us to reinvent the wheel. Just choose one of them. Liaise and interact a lot with the various stakeholders, with the nursing staff, with your catering staff. Train your users. Here in Scotland, we pay a lot of attention to train our nurses and make sure that there's an ownership in this process, so you don't always have to have a dietitian training nurses how to do screening. In routine clinical practice, you can train nurses, and nurses can train their peers. Of course, very important to roll out in clinical practice to evaluate the completion rate, so essentially how well you perform nutrition screening in routine clinical practice, to evaluate its performance, so essentially, do you pick up children that you would like to treat and see, or you pick up children who are what we call false positive referrals, and essentially you upset your dietetic colleagues. You have to think how this new method will introduce will influence your dietetic and nursing workload, to collect, of course, feedback and look at this kind of like data you have collected and make sure that you go back and revise your method and decide about the next steps. So the question is, how well do we actually do in Europe? How often do we apply nutrition screening? And one of the positions I used to have in the past was to be leading the quality of care on nutrition of the ESPGHAN quality of care initiative. And this is the output, one of these processes. We essentially surveyed 28 different pediatric hospitals in 28 different European countries, and we asked them various questions. But one of the most important questions we asked them is how often they perform nutrition screening, and most importantly, if they have any nutrition screening in routine clinical practice. And as you can see from the results of this slide here, 40% of the hospitals did not have a nutrition screening tool in routine clinical practice. So when we try to work out what was the case, what are the barriers of nutrition screening in routine clinical practice, why healthcare professionals do not use this. We carried out another study with one of my very close colleagues, Koen Hausentraal, who is the current chair of the clinical malnutrition special interest group in ESPGHAN. And we tried to work out why this is happening, why people don't introduce a screening tool in routine clinical practice. Was this because there was no method to use? And as you can see, this was not the answer, okay? Only 15-16% of the people thought that they didn't have a method to use. But as you can see, the most common answer was that the majority of the healthcare professionals did not think that nutrition is important for patients' outcomes. So there was, in other words, a very low staff awareness of the role of nutrition on patient care. And this is something quite disheartening, despite the amount of evidence we currently have to suggest that nutrition is very, very important in improving patients' outcomes. And with this slide, I would like to close my presentation, and I believe that we'll have a Q&A session at the end of this webinar. Thank you very much for inviting me again.
Thank you very much, Kostas. As always, a brilliant presentation and a topic I know you like very much, and I hope we will have questions at the end. Now we move to the last topic, in which Lovisa Telborn, which is a dietitian, especially working in the pediatric surgical unit of the Hospital of Lund, will guide us through the use of a nutritional screening tool in the context of surgical patients. Thank you very much, Lovisa, for your talk.
Thank you for the introduction. So I will share my screen. Yes, so I'm working as a clinical dietitian in the Department of Pediatric Surgery, and I also do research on diet, nutrition, and growth in pediatric surgical patients. So I will talk about available screening tools, and also with a more practical approach on how we can use it in the clinical care. So this is an overview of 4 of the available nutritional screening tools, and it shows, I'm sorry, this is just, right? It was just this window that, so sorry. So this is an overview of 4 of the available nutritional screening tools that are used in pediatric care. And it shows both the population that was included in the development and evaluation, and the components of the tools, and the availability of validation studies. So iNews is developed for infants and young children, and STAMP, PIMS, and Strong Kids are the 3 most cited pediatric screening tools in the literature. A main difference in the use is that the Strong Kids tool doesn't need any measurements of weight and height. Children admitted for surgery were included in development and evaluation of all these 4 tools, but there's no specific tool that is developed for pediatric surgery specifically. So these are all general tools. And all these 4 tools are tied to action plans depending on the outcome of the screening. Comparing these 3 tools for children, it has been shown that identification and classification of malnutrition risk varies across the tools. And all 3 tools shows an association between risk score and length of hospital stay. And as Kostas said, it has not been concluded that any one tool is superior, and neither ESPGHAN or ESPGHAN recommend any specific tool, but highlight the importance of using a nutritional screening tool and to do this routine screening in clinical practice. So I will show you the iNews score, and this tool is developed for infants. It consists of 4 steps. And the first step is if a health professional is concerned about the weight weight gain of the infant. And the second question is if the infant had a reduced intake for at least the past 5 days. The next step is to check the weight of the infant in the table with cutoff values, depending on the age and sex of the infant. And finally, you add the scores from the different steps and record the total score. And in this case, if the total score is equal to or greater than 3.9, then the patient should be referred for further assessment. And this is a decision tree based on the components in the tool, showing that a very low weight alone is considered as a high risk, and then the child is in need for further assessment. If the weight is low, but as the cutoff values in column B in the table, in combination with that a health professional is concerned about the weight gain, then you refer for further assessment. And if the weight is above the values in column B in this table, in combination with that the health professional is concerned for the weight gain, and if the child has a reduced intake for at least the past 5 days, then this infant is assessed as a risk for further or for undernutrition and in need for a further review and assessment. And this is how the STAMP tool looks like. And this tool evaluates 3 components: clinical diagnosis, nutritional intake, and measurements of weight and height. And I will not go through this one more. This is the PIMS tool. And here I just want to highlight the step 4, which could be of special interest in pediatric surgery, I think. This question takes some future aspects into account. If the child's nutrition will be affected by the recent admission or condition for at least the next following week. So do we for at least the next week assume or predict a decreased intake or increased losses? And this could be the case of children having a stoma created, for example. And major gastrointestinal surgery with the preoperative and the postoperative fasting period will impact on the child's intake, of course. And this is the Strong Kids tool, and I will give you a practical example of using this tool. So I'll go through it with a case, and my case is a 9-year-old girl. She has no chronic disease and she's growing well. She presents to the pediatric emergency department due to intensive abdominal pain and a loss of appetite the last days. It appears that she has an appendicitis and she is admitted to the hospital for surgery. So in this nutritional screening, she doesn't score for any underlying illness, and we don't consider the appendectomy as a major surgery. With a subjective clinical assessment, she doesn't seem to be in a poor nutritional status, but she has had a reduced intake the last days, and that is 1 point. There is no clear weight loss, so the total score for this child is 1 point on admission. The Strong Kids tool has a 3-graded scale on the risk of malnutrition or the need of further assessment with an action plan with intervention and follow-up. The score 1 to 3 points means a medium risk, and the intervention assumed is to consider nutritional intervention, check weight twice a week, and evaluate the nutritional risk weekly. If we had received 4 or 5 points, then the child would have been considered as being at high risk, and then we would consult a physician and dietitian for full diagnosis and individual nutritional advice and follow-up plan. Further on, at 1 week after admission, it turned out that it was a perforated appendicitis, and the surgery became more complicated, and the girl also developed a sepsis. So she was held fasting for a longer period than expected from the beginning, and she was allowed to eat. Later on, she still had a loss of appetite. And we also got some new information on that she was a picky eater, and she was very selective in her food choices. And this was making it even more difficult to start eating at the hospital. So the total score on the second screening was increased to 3 points. So she is still considered to have a medium risk. However, we started a nutritional intervention with oral nutritional supplements, which she accepted. And this is an example of how it can look like with beforehand healthy patient, that the course changes during the hospital stay. This is an algorithm for nutritional screening, assessment, and follow-up of nutritional status. So starting on admission to the hospital, we measure weight and height and conduct the nutritional risk screening. And this is usually performed by nurses. If undernutrition is unlikely, then we follow the standard nutritional care. And here I would like to point out the reassessment in children where undernutrition is unlikely, or we doesn't need that, they are in need for further review. But to reassess this with a predetermined time interval during the hospital stay. If we assess and find a risk for undernutrition or a need for further review, then we refer for a full nutritional assessment, as Kostas described, and that is usually made by a dietitian or in a team. And then we develop a nutritional care plan. And then, of course, it's also important for these children to do this reassessment during the hospital stay. And I would also like to point out the importance of a follow-up plan at discharge. So this is an example of how we can work with nutritional screening more practically in the hospital setting. So thank you for that. And I will end my presentation and stop sharing.
So thank you very much, Lovisa and Kostas, and indeed to ERNICA for those great talks. See, we're rapidly running out of time because an hour goes really quickly, it turns out. There's one question in the chat, which I'm going to adapt slightly for Lovisa and Kostas. With the question in the chat is on using nutrition screening tools on a home enteral nutrition paediatric community neurodisability caseload. So my question is, have these screening tools been assessed for their validity in out of hospital settings, or are they mainly the validity is tested for in hospital settings, or are there any other aspects to consider?
Yeah, I can take this. First of all, if a child is on home enteral nutrition, it means that they should already be under dietetic care. So there's no point screening these children because they're already under dietetic care, if it makes sense. But if you've got children in community, let's say who have like CP, and they may kind of like be at risk of undernutrition, at least here in Glasgow, there was at some point this idea of asking community nurses to perform nutritional screening in these children who are looked after pretty much most of the time in community. We didn't make huge progress, and I know that some of these screening tools have been tested, but my gut feeling is that even if you take any of these three screening tools which are currently available and you use them in this population, they will perform equally well. It doesn't necessarily need the children to be in the hospital. Okay, so as long as you've got someone who can perform nutritional screening in these settings. There's a lot of interest also about self-screening, so essentially or ask parents to perform the screening, particularly for those children who have long-term conditions. Variable results about this, so obviously it's very difficult to ask parents to measure height accurately. So weight is usually not a problem, but when you want to assess the nutrition status of a child, it's very, very important to take consideration the growth in relation to the weight of these children.
Thank you, Kostas. Lovisa, do you have anything to add to that?
No, I agree. And as you said, if there's if the child has enteral nutrition, then the child would already be in a nutritional care team, including a dietitian, just for that specific question, yes.
I think we're already at our time limit, but I'm just going to ask the audience if anyone wants to put their hand up. We've probably got time for one quick question. Okay, in that case, then I'm actually going to take an opportunity to ask a question, which is to Costas. And were you surprised at the results of the survey that was done among the 28 hospitals, and that lots of people seem to not consider that nutrition was important in leading to an outcome? I would have thought that was quite a disappointing finding.
Yeah, that's true. And the non-believers are usually surgeons. Okay, so we have good data, not from our group, but from elsewhere, that quite often, not the surgeons who are in this call or in this audience, are not great believers of the benefit of nutritional care. And at least here in Glasgow, we have demonstrated cases of surgical patients who were at high risk of undernutrition, and they wouldn't even have a measurement of height. Weight, they normally take it because the surgeons need this to calculate drug doses and everything else. But as I told you before, it's very difficult to assess a child's nutrition status in the absence of growth height measurements. So that's one thing. The great believers are obviously people who are pediatric gastroenterologists, and because these people are kind of like see a higher proportion of children who will be at risk of undernutrition. And there was another thing I wanted to mention, but I just forgot it. Yeah, I think that's the short answer to your question.
Oh, thank you. And,
yes, sorry.
If
I'm allowed to. Yes, so the other important thing is that you have also to remember which are kind of like the clinical quality indicators which apply in every country. As you probably know, Simon, in the UK, it's mandatory to use nutrition screening. If you don't have a nutrition screening process in routine clinical practice, your hospital cannot operate. So there is a huge push and pressure from a hospital to introduce that. I come originally from Greece. This is not mandatory. I don't know what's happening in Italy. Most likely it's not mandatory, but I don't know that
now we have the problem of having a regional healthcare system. So some of the regions are now having a mandatory screening in all pediatric patients, not all of them, but we are trying to make it up.
So it depends very much on the policies and kind of like the guidelines around that. So in the UK, I would expect that every single hospital will have a screening tool in routine clinical practice because this is mandatory. In other countries, pretty much like in Italy, as Lorenzo said, it depends very much on the region, in the hospital. So the results we received are not surprising. They were pretty much expected.
So it's all down to the surgeons. And obviously, ERNICA, here we have someone that is convinced of the importance of nutrition.
Yeah.
But then it looks like we've got some work to do within ERNICA and EUPSA, maybe also a little bit in ESPGHAN, to try to persuade surgeons and others of the importance of this.
Yeah, I would expect that the GI surgeon will be more motivated. I'm trying to think about other kind of like surgical specialties where they won't be as much motivated about nutrition. And it makes sense because when you operate the gut, obviously you change the alimentary tract, so you increase the risk of undernutrition. I wouldn't expect that, GI surgeon will be more interested about this topic, but surgeons who operate, I don't know, other type of conditions probably won't, like let's say orthopedic surgeons.
I totally agree, but it was very nice to hear from ERNICA that the better nutritional status is not only in abdominal wound, it's something that will help in all kind of wounded operation. So of course we are maybe a bit more aware of it, but it's something that we need to do probably awareness campaign also for other colleagues and other specialities.
Okay, so if no one has got any further questions, I would like to thank all the three speakers, so Annika, Costas and Louisa, and thank also my co-chair Lorenzo for helping chair this, and also to all the people that have helped organise it, especially Sarah and Rome from ERNICA. Thank you all for attending, and I hope you found it interesting and stimulating.
Thank you very much.
Thanks, everyone.
Goodbye, everybody.
Bye.
Thank you very much. Bye.